Hi, I'm Mark Link. I'm a professor of medicine at UT Southwestern Medical Center in Dallas, Texas, United States. The session today that I presented at was a session on athletes. And there were 4 talks on athletes and focusing on the breadth from sudden cardiac death to atrial fibrillation in the athlete. You know, the athlete represents what is thought to be the healthiest segment of the population, and therefore any diseases that happen to the athlete are thought to be exceptional because they are thought to be protected from disease. And that's clearly not the case, that athletes are subject to sudden cardiac death and they are subject to atrial fibrillation. You know, for years, based on Barry Marin's data, we thought that hypertrophic cardiomyopathy was the most common cause of sudden death in the athlete. And the more that we're studying this and the more contemporary data that we have shows that HCM is probably not the most common cause of sudden death in the athlete, but there are other causes that are even higher, such as autopsy negative or normal heart sudden cardiac death. That's come to be the leading cause of sudden cardiac death in the athlete in all of the contemporary series. Yeah, that's a very important question. You know, in the United States, based on Barry Marin's data for the last 20 years, hypertrophic cardiomyopathy has been shown to be the most common cause of sudden cardiac death in the athlete. That has not been reproduced in other countries, including Italy, including Israel, and including Asian countries. It's clear that hypertrophic cardiomyopathy is as prevalent in Asian countries as it is in the United States, but what's not clear is that the incidence of sudden cardiac death in athletes appears to be, HCM appears to represent a lower fraction in other countries, and that autopsy negative sudden cardiac death is the most common cause of sudden cardiac death in these other countries. Yeah, I think that if you look at the screening that's done in the United States, even that, which is history and physical, has really not been shown to reduce sudden cardiac death. I think the most important thing is that, you know, patients and pediatricians, or patients and their families, have an ongoing relationship with a physician that can treat them for a multitude of diseases. I actually think it's more important to have a pediatric well visit than it is to be screened in a high school or grade school. I think that anyone that's going to screen or take care of patients should have the credentials to do so. And that's not just physicians anymore, it's DOs, it's nurse practitioners, it's you know, there are many other people that now can take care of patients, and I think that any of those with those qualifications should be able to take care of these patients. I think the important take-home concept I have is you'll never prevent all arrests, no matter what kind of screening program you have, because you'll never pick up all those patients. So the most important thing in my mind is really to concentrate on resuscitation. I think all athletes, I think all coaches, I think all trainers should know basic CPR. They should know how to do chest compression only CPR. I think that should be a universal requirement for graduating from high school, and that in and of itself is going to save more lives, far more lives than any screening program. I think also having AEDs available in the community is important. I think that it is not the only thing, because if you don't have good CPR, having an AED is not going to make any difference. So I think CPR that everyone knows how to do, and AEDs scattered in the community.
Anything else you would like to add?
I think that we can and have been reducing sudden cardiac death and increasing resuscitation from sudden cardiac arrest in the field, and that has to do with improvements in resuscitation. And again, I think that's what we really need to focus on. I think this has been a fantastic program. I looked through the program yesterday and today. I've been to many of the conferences already. I think it's a fantastic program that covers the breadth of EP. And so I commend the organizers on that. And I would say to the future chairs, take a look at this program and see the successes of this program, which I think have been many.
My name is Jeannie Poole. I am the section head of electrophysiology at the University of Washington in Seattle, Washington. This morning I chaired a session that was called How Do I Change My Practice After the Big Clinical Trials? This session highlighted the findings from a number of large trials that have been conducted over the last several years. These are all trials that had very important outcomes that have the ability to change our practice and to lead us to future studies to take the next steps that these studies all laid a great foundation for. I'm not sure that any one of these trials was more impactful than the other trial. They were all addressing very critical questions that we needed to understand something further about the particular patient population. So for instance, the Danish trial was the first trial that was discussed by Dr. Lars Korber, the principal investigator of that trial. This trial was a study of patients with non-ischemic heart failure, so no coronary disease, and patients were randomized to receive an implantable cardioverter defibrillator or to not receive one. And the patients who received the ICD did not benefit. And that was really an unexpected outcome. And there were some very unique aspects of this trial that we have now had to ponder. Those questions include which patients should receive an ICD. Are there some patients who, in fact, the risk of sudden death is so low that there's no benefit of a defibrillator? And another question is, how can we better identify those patients who, in fact, are most likely to benefit from an implantable defibrillator? So the Danish trial has really got us all thinking a lot about what are the next steps in trying to understand this better. Other key messages, in addition to what I discussed about the Danish trial, include the results of CASTLE AF trial. The CASTLE trial was a trial of atrial fibrillation ablation in patients with heart failure, and it demonstrated a reduced mortality for patients who received ablation versus medical therapy. That's a very important study because we haven't really been thinking about that patient population as a group of patients who ought to be considered aggressively for atrial fibrillation ablation. The next trial that was discussed was the Cabana trial. This is also a trial of catheter ablation of atrial fibrillation. It was a very different patient population than the CASTLE trial. That is, that these were patients who not only had heart failure, but in fact more patients did not have heart failure. Overall, the mortality was not decreased by intention to treat analysis. However, patients who received catheter ablation benefited in many other ways. Their quality of life improved and recurrence of atrial fibrillation was less. Also, sub-study analysis, which has been started in the Cabana trial, looking at the heart failure patients, is suggestive that the results in the heart failure patients are going to look similar to the CASTLE patients. So that's a very important outcome of that study. This was a study that randomized patients who were not candidates for an implantable defibrillator, generally because they needed to wait for some time period to have their heart failure reassessed. And patients were randomized to wear a WCD or wearable cardioverter defibrillator or not. And this study did not demonstrate an overall benefit on mortality, which was quite perplexing. But if you dig into the trial a little bit more, what you find is that the patients who died and were in the group that they were supposed to be wearing the defibrillator actually did not have the defibrillator on at the time of their death. And so it does raise the question about what the real outcome is of this study and how it changes practice. Most electrophysiologists at this point in time are continuing to consider it for patients that they're concerned about. But better defining those groups of patients that are the best patients to use this device as potentially a bridge to an implanted device is something that we yet need to explore further with more studies. Let's see, what was the first part of that question again? Sorry, the first part.
The message to the organizing
Oh, the message to the organizing committee. Okay. APHRS this year is fantastic. I've really enjoyed myself both yesterday and today. All of the presentations have been excellent. I think it's been well organized. The topics are very important topics. And I would say that for next year, APHRS should use this year's as a great model of how a conference can be well done. Oh, you don't want me moving around? Am I moving?
Right.
I tend
You're
to move.
now moving around.
Tend to move when I talk.
I understand.
I'm holding my hands so that I don't use my hands. The Asia Pacific Heart Rhythm Society 2019 meeting has been a fantastic meeting so far, and I'm looking forward to the rest of the meeting. It's been well organized. All of the sessions have been very interesting and well conducted. Very important topics have been discussed. Topics which what? I have to think of. This is harder than to describe things. Let's see. Topics which make us think about where to go in the future in terms of more studies. I would suggest that for APHRS, those who are going to be planning the next meeting in 2020, that they'll be able to look at this year's meeting in 2019 as a great model for how to have a successful meeting.
My name is Tanyanan Tanawutiwat. I'm from University of Mississippi Medical Center from United States. I'm here at the APHRS to present the importance on the sleep quality and arrhythmogenesis. The sleeping is very important because it's one important component of life, and the obstructive sleep apnea is a well-known sleep disorder that has been investigated and that show the association of arrhythmia, including atrial fibrillation, ventricular arrhythmia, or bradyarrhythmia. However, there are other components of the sleep that can contribute to the arrhythmia as well, including the insomnia, sleep disruption, and sleep duration. So there's a lot of study currently ongoing to investigate more further on the sleep duration, disruption, and insomnia and its association with arrhythmia. Other than that, there are also a lot of future direction that perhaps we can pursue the research on that. The wearable device that people wear at this time can show that the sleep quality and also arrhythmia that it records as a personal record. Hopefully this will guide the future research. Also with the device that have the minute ventilation that can also detect the obstructive sleep apnea, and it can associate with arrhythmia detected by the device. And hopefully this is going to be another light on the research in the future as well. In order to live arrhythmia free, I think the lifestyle modification is the most important. Sleep is one of the important part of the lifestyle. I think the adequate sleep and good quality of sleep play an important role on that. So for the public, I would say that to have a good duration of sleep, not too long, not too short, and good quality of sleep. Also for the screening of the obstructive sleep apnea, if you have any suspicious symptoms, that's also important in order to prevent arrhythmia in the future. The most recent study was published in JACC was about the sleep duration and cardiovascular risk. However, it's not directly on the arrhythmogenesis. But it showed that the patient who sleep less than 7 hours or sleep more than 9 hours have increase of the cardiovascular risk. So therefore, the adequate amount of sleep doesn't mean that sleep more is better, but in fact, it's a sleep in a good amount is better for the cardiovascular health. So I think for the public population, I think it's important to know that what is the impact of the good quality of the sleep to the arrhythmogenesis. Currently, there's a more study toward on how to improve the quality of the sleep, what is a good quality of the sleep related with cardiovascular risk. The most recent study from Journal of American College of Cardiology showed that the patient who sleep less than 7 hours or who sleep more than 9 hours is increased cardiovascular risk. So therefore, it doesn't mean that sleep more is better. It means that adequate sleep need to find out what is called adequate sleeping. Other than that, there are also a lot of things that help in the lifestyle at this time. For example, the wearable device that the people wear to monitor tracking their exercise, heart rate, and also the sleep quality. Hopefully this device in the future will give us more information for the individual patient, and we can correlate the sleep quality with the arrhythmia better. A lot of new technology nowadays, including all the wearable device, have a lot of information that we obtain from the individual patient, including the sleep quality, arrhythmogenicity, or the patient activity. I think this is important to correlate the lifestyle with the arrhythmogenesis of the patient. So I think this is going to help a lot in terms of to explore how lifestyle related with arrhythmia.
I'm Gregory Lipp. I'm the Price Evans Professor of Cardiovascular Medicine at the University of Liverpool and Director of the Liverpool Centre for Cardiovascular Sciences in Liverpool in the United Kingdom. Today in the plenary session on atrial fibrillation, I was asked to address the aspects of stroke prevention in atrial fibrillation. And with stroke prevention, we start off with risk assessment. And perhaps the take-home messages are that keep risk assessment simple, practical, and the starting point, therefore, is the default should be stroke prevention unless the patients are low risk. How do you define risk? Well, I would make a plea to go for an approach that defines who is low risk, because if the default is stroke prevention, unless they're low risk, the first step should be to identify the low risk patients who do not need antithrombotic therapy. Subsequent to that, patients with one or more established stroke risk factors can be considered for stroke prevention, and stroke prevention means oral anticoagulation, whether given as warfarin with good quality anticoagulant control that is a high time in therapeutic range, otherwise these days with a NOAC, a non-vitamin K antagonist oral anticoagulant, or sometimes called a direct oral anticoagulant. Now, it's important to also appreciate that stroke risk is not a static one-off process. Risk factors are dynamic, and of course, over time, patients get older, they acquire new risk factors, and it's very important to reassess stroke risk at every opportunity during follow-up. Now, with regard to managing patients with atrial fibrillation, stroke prevention is important, but it is one component of managing the holistic aspect of atrial fibrillation management. And why is that? Patients with atrial fibrillation very often are looked after by general practitioners. They may also present to the emergency room and also be seen by non-cardiologists. They may be seen by cardiologists, and there will be differences between cardiologists and non-cardiologists who are interested in cardiac arrhythmias with regard to the approach. And of course, the patient is central to all this. They may well get different messages from the general practitioner, the non-cardiologist, and the cardiologist. And it's wise to have a streamlined patient pathway that is uniform, going from general practice to the emergency room, to the hospital specialist, to the cardiologist, to the non-cardiologist, so that the patient gets a consistent message. How is this consistent message? Well, it's actually very simple. A is anticoagulant. A is anticoagulation to avoid stroke. What is B? Better symptoms, because this is where we decide on rate control and rhythm control for the management of symptoms in patients with atrial fibrillation. And what is C? C is proactive management of cardiovascular and comorbidities and optimizing those, because if you are complying with A, B, and C, the evidence as we have it shows that these patients have far better outcomes compared to those who are not compliant with an ABC approach.
Well, we have had just a very important session on Brugada syndrome, a disease that it is usually considered as a rare disease, but we have to come to realize that this is not the case. This is a very frequent disease, and that actually, as a physician, it is very important that when you have patients that might have symptoms that might suggest arrhythmias like syncope, palpitations, or a family history of sudden death, that you think about the possibility of Brugada syndrome. Now, what we have been discussing particularly is what to do with the patients that are diagnosed with Brugada syndrome, usually because someone else in the family has Brugada syndrome, but who have no symptoms at all. They are completely asymptomatic, and they might have even a completely normal electrocardiogram. And the disease, Brugada syndrome, is discovered usually after performing an Ashmalin or a Fleck-eye night test. Now, what to do with these individuals? Well, this problem, which was really controversial in the past, has become today a little bit more clear. I will not say that we have all the answers to all the problems, but we know nowadays that a large majority of the patients with Brugada syndrome will never have any symptom before they develop sudden cardiac death. Thus, if the patient has had a syncope or not is important in the sense that a syncope is always bad news in Brugada syndrome. But if you have had no syncope, this doesn't mean that the patient is not at risk of sudden cardiac death. Now, we have now a scoring system that allows us to evaluate the risk of patients with Brugada syndrome. This scoring system, published by Dr. Sieira in the European Heart Journal in 2017, considers the symptoms, but considers also other factors in Brugada syndrome, like, for instance, the family history of sudden death, the electrocardiogram, and the results of programmed electrical stimulation of the heart that actually are as important or even more important than the symptoms to determine the prognosis. So today, we have been able to define the fact that symptoms are not actually one of the major issues in risk stratification in Brugada syndrome, and that an asymptomatic patient, a patient without any syncope, that actually might be also at risk of sudden death, and that you have to stratify the risk, and when you consider that the risk is high, the patient should be appropriately treated, either by ablation or a defibrillator, or ideally at the present time with a combination of ablation and an implantable cardioverter defibrillator. At the present time, we are actually starting a new era in the diagnosis and treatment of Brugada syndrome. The reason is the major entrance that genetics has done in clinical cardiology. As we discover more and more genes and mutations involved in Brugada syndrome, the hope that we will understand this disease better and better increases. That means also that we will understand much better the pathophysiologic mechanisms, and that might allow us to define new therapeutic strategies which might differ from the present ones, which are the defibrillator and ablation. These new techniques, of course, will have to do with proteomics, epigenetics, with all the mechanisms that actually really are the ones that determine the prognosis of Brugada syndrome. The pathophysiologic mechanisms, understanding them, this is the real clue to the benefit to our patients in the future. In terms of Brugada syndrome, it is fascinating actually that we are holding this meeting here in Bangkok, one of the areas, as you know, that is affected by Brugada syndrome in a major way. The whole South Asian, Philippines, Indonesia, Japanese, Chinese area has Brugada syndrome as an endemic disease. We do not know exactly the causes of these endemic proportions of Brugada syndrome in Thailand. But I think that the efforts that are being done by the University of Bangkok and the other Thai universities in collaboration with universities of the United States and of Europe will bring us to new knowledge on this disease. It is important that the cardiologists, but not only the cardiologists, also the general practitioners and every doctor and every member of the medical community, including nurses, actually thinks of the possibility of Brugada syndrome. Anytime that something might be wrong with the heart, think of Brugada syndrome, because this disease is really attacking the people here in Thailand. And the only way to treat it is, first of all, to recognize it. I hope that in the next years and in the next conferences, we will be able to see major breakthroughs in the diagnosis of treatment of Brugada syndrome. But we really have to count on you, all the medical professionals, in, first of all, thinking and recognizing the patients that have this disease.